Hi, this will be the fourth video in this series of 4 mini videos on DBT's suicide crisis protocol in the intensive training. So we just got through risk factors and protective factors with respect to suicide behavior when you're dealing with that. And now we're going to go into the next slide that was there is really about the what's called the Linehan Risk Assessment Management Risk Assessment and Management Protocol. So L-RAMP, R-A-M-P, and this is really nice for us after what I've been through because it really completely matches up with the kind of risk factors and the kind of thinking I've been sharing with you. And it sort of systematizes it, puts it down on paper in 7 pages that you can fill out as a clinician after you have gone through this, or even referring to it as you go through it, because it helps give you some ideas about what to assess and what your options might be. So it's very consistent with the DBT suicide crisis protocol, so the LRAMP is really good for us. It also is very systematic, so it's very good to have something like this to be checking on, because even if you think you remember this protocol, you think you're doing all of it, you think you have good intuition, you know, it's really good to just have a checklist and to be going down and making sure that you've done everything. And finally, it allows for documentation, because as you go through it, you document risk factors, you document what your choices were, you document what choice you made and why you did or didn't hospitalize somebody, or why you would or wouldn't recommend that. And at the very end, you sort of go over what your final disposition is and why. And so you've got everything documented, whether it's for your memory, for communication to other team members, whether if anything were to ever come up and your liability was in question, you've got really good documentation. So it is a 7-page document called Linehan Risk Assessment and Management Protocol. And if you went to an intensive, you would have gotten this. And it has many sections, but you'll see if you go through it step by step. After the reason for completing this is if some incident happens or risk is up, and there's various things you document about why you're completing it, and then you describe in brief form the specific incident or behavior that occurred or that you're worried about. Then you move on to a structured formal assessment of suicide risk, and you point out that either you did it or you didn't do it, and why you did do it or why you didn't do it. And it gives you lots of options. And you move on to the 4th section, which is on acute suicide risk factors. These are basically match up with the ones I've been teaching you. And they go, there's quite a few of them, but just like for me, the tip, dart, harm, impale, that list. Then the suicide protective factors, which matches up just with the ones that I taught. And then there's the suicide risk management. Now you've assessed risk. Now what are you going to do? And it gives you lots of options for what to do, both in terms of the disposition as well as just step by step. What are all the things to do, which we're going to go over now. On to the final disposition of saying what you think needs to be done and why, so you've got everything documented. So that's part of risk management with suicide with DBT. Now let's move on. We're moving on to a suicide crisis protocol. Back to the protocol and sort of step by step, what do you do? So the next slide, which is on those who just went through the intensive with me, page 67, but for someone else it might be somewhere else in there, but it says DB2 Suicide Crisis Protocol, slide number 1 on this of 2. And so the first thing you do is what we've been talking about, assess long-term and imminent risk of suicide. Then the next major point is that you focus on here and now problem solving. So what that means is the following, several things. You zero in on the painful affect. You make a connection. You validate affect. You validate, well, no wonder. I understand things are really bad. I know you're really scared. I know you're really hopeless. I can see that, and I can see why you feel that way. But you, on the other hand, provide a more hopeful stance, a problem-solving stance. It's sort of like, I get why it's that way. I know you, or I hear the circumstances. I know it's bad. I know that you're in a deep hole. It's hard for you to see your way out. It's hard for you to see what to do. It's hard for you to think anything will work. I'm looking at this from a different perspective. I know you enough to know you have a lot going for you, if only we can get things going. And there's a life for you, a really good life for you. And we've got to work on that, And so you remain hopeful, you remain optimistic, you remain in a problem-solving point of view. You give direct advice, probably more than you typically do, even in DBT. And you give suggestions. You frame possible solutions for the person when possible in terms of DBT's skills, so it connects up with what they're learning elsewhere in the program. You predict future consequences for them for different action plans. One of the things that goes when you're suicidal and you're that distressed to think of killing yourself is that you become less good at thinking of the big picture, thinking realistically or flexibly, and definitely thinking about consequences of things. So very obvious consequences of you killing yourself, you might not think about. So you want to predict that if you do, and at this point, very important things come up, like if you're having this discussion, you say, so you're figuring this is all right to do, even given your niece and nephew that looked up to you and love you and depend on you. You're thinking of doing this. What are you going to do about your 2 cats that you love so much, and that you're the only one who can really take good care of those cats? I mean, have you thought this through? I mean, you're just seeming to think you're just going to wipe out yourself as a burden. That's so far from what you are. That you're leaving out a lot of possible consequences. So you're helping them think about this. Again, problem solving. When you hear maladaptive thoughts, ideas, constructions, beliefs, and things like that, confront them directly. Say, well, I'm sorry, that's just not true. No, you're not somebody that the world will be better off without. It's just not true. No, it is just not true that you're going to be this way forever. No one has just been this way forever. It's getting through this, and you're a survivor up to now, and you could be a survivor, and you're going to find out there's better stuff on the other side. When people do anything that's adaptive and pro-treatment and trying to hang in there, you reinforce that. And you emphasize the use of skillful behaviors even here and now. So you shape the person. So if the person's being at all skillful in interacting with you right now by being upfront or telling you things or being honest or having the courage to explain something, I will then reinforce them for those steps. The other slide on Suicide Crisis Protocol now we go further. So notice the first step is assess suicide risk. The second step is focus on here and now problem solving as opposed to long-term problem solving. That's for sessions. Then you're on to, okay, you want to create a plan to work together. And when I create a plan, I draw a lot from those high-risk environmental factors and the high-risk behavioral factors. Remember those? The environmental factors like low social support, high degree of stressors, having the means available, being in a minority status. That these things I'm drawing from because you can do something about those, or the behavioral factors like hopeless thinking or rigid thinking or intense emotional, turbulent emotions, or impulsive actions. I'm trying to address some of these things in the moment. And what's really interesting is that even though somebody is going to kill themselves or intends to kill themselves because of huge numbers of things that have gone on in their lives that they think they can't get past, in fact, if you zero in on 1 or 2 things to work on out of the list I was just talking about for 20 minutes, you get farther in terms of helping somebody be motivated to hang in there than if you just sort of doing a survey of all the things, positive and negative. Get into one of them and work on it and try to fix something that's really stressful. Try to come up with some action plans for a relationship that the person thinks they can't tolerate anymore and therefore they have to die. Things like that. So make a plan drawing from high-risk environmental factors and high-risk behavioral factors. Now you need a commitment to the plan from the patient. So of course you need your own commitment to it first. And then you're trying to explicitly ask, say, okay, so how about if what you do in the next day is the following, 1, 2, and 3, and you get very specific. Here's what I'm asking you to do now that you and I have been batting this back and forth, is I'd like to ask you to do that. And I might present some arguments for the plan. I might push it pretty hard compared to if I'm just doing standard DBT, not in a suicide crisis. So I want to tip the scales in favor of the advantages of staying alive and following through with the plan and the disadvantages of not doing that. So I'm arguing for the plan. I push a lot. I'm going to remind the patient of those negative consequences of suicide. I often make the statement that, it's an irreversible solution. You can do it only once in your life. So I really think there's more to be done now. There are other things you wanted to do in your life, I think, other than what you've done up to now. So let's make it so you can do those. Remind the patient of the negative consequences of suicide, while still always emphasizing that, of course, the person does have the freedom to choose now or in the future. The next thing is you've made the plan. You've tried to get as strong a commitment to the plan as you can, and you also use DBT's commitment strategies to try to do that, by the way. You use shaping. You use foot in the door, door in the face. You use pros and cons of making certain choices. You remind people of things they've done that are really hard before and try to link this to those, sort of connecting prior. You emphasize the freedom to choose, but you really stack the deck against choosing to do suicide. Now you troubleshoot the plan, which is to say to yourself, okay, we've got a plan, we've got a commitment, we've got an action plan. Patients may be agreeing to do this to some degree. Now, just assume at the end of this contact that you're having with the patient, the plan to kill oneself is just going to come back. The feelings are going to come back. It's very different to have you there and have you not there, not talking with them. So troubleshoot the plan. In other words, what do you do if it doesn't work? What's the next step if there's a recurrence of the crisis response? What are some of the cues of recurrence that are likely to happen? In other words, what's going to trigger you into a recurrence of your decision to kill yourself? Let's anticipate that. Let's cope ahead with that. Let's think about that. Let's structure your next day and until we meet in our next session. And let's plan for that eventuality. And revise the plan, have a backup plan, plan 1 and plan 2. And then at the end of the contact here of the suicide crisis protocol, it's sort of like reassess risk, the suicide risk. You might hear that it hasn't changed very much, but generally going through what I'm describing, if the person will go through it with you, even reluctantly, hits on something here or there, if you go through all this stuff, that makes them think twice and makes them revisits their thinking about this, broadens their thinking, widens their perspective, and makes it more likely that they're going to make a decision for the time being to stick with it. And then you work with them in the next session, going back to standard DBT, but with an eye to the crisis and how close you are to the crisis. That's it for the protocol. In the intensive, in part 2, we'll be doing a demonstration. Crisis role play, myself and then all of you. So make sure you learn this protocol. Okay? Thanks, guys. I'll see you. I hope this was helpful. Bye.